In this presentation, we're going to discuss two exemplars, including spinal shock and neurogenic shock. They are distinctly different types of shock related to spinal cord injuries. First, let me say that as a result of spinal cord injury, people can develop a neurogenic shock. But when we say neurogenic shock, we're talking about a life-threatening condition caused by irregular blood circulation in the body. In fact, we've already memorized the fact that neurogenic shock is an example of a distributive shock. So we have already covered this information, but not specifically in terms of neurogenic shock. So we'll go into that review again. And also, we would like at this time to talk about all of the different things that can cause spinal cord injury. You'll see on this list here, the National Spinal Cord Injury Database, that motor vehicle accidents account for the majority of spinal cord injuries. Next on that list is falls at 18%. But violence, certainly, and sports injuries can cause spinal cord injuries as well. Certainly gunshot wounds that sever the spine, knife wounds, these type of violent activities can cause spinal cord injury, and sports injuries as well. The majority, over 55% of the cases of spinal cord injury occur in the age group of 16 to 30 years of age. Okay. Trauma or injury to the spine can cause this disruption. It can occur after damage to the central nervous system, such as spinal cord injury. So remember, neurogenic shock results from a spinal cord injury. Okay, that's different than the other distributive shocks we talked about, septic shock and anaphylactic shock. This is neurogenic shock. It's not caused because of an infection. It's caused because of a spinal cord injury or illness, condition, or disease of the spine can also lead to neurogenic shock. But there has to be something that has caused damage to the spinal cord, okay, to develop neurogenic shock. And we're going to talk in more detail about that as we go forward. Here's some emergency signs and symptoms that somebody has had a spinal cord injury. They may have extreme back pain. They may demonstrate weakness or incoordination or paralysis of any part of their body, numbness or tingling or loss of sensation in the hands, feet, and fingers and toes as well. Loss of bladder or bowel control. Difficulty with balance and walking. And impaired breathing after injury. So these are some of the signs and symptoms that would indicate or point to the fact that an individual has had a spinal cord injury. It's always much better if we can prevent this from occurring. So this is a list of the advice that can reduce the risk of spinal cord injury. Number one would be drive safely. Okay. Before diving into water, make sure you know the depth of the water. I've seen several patients who have dived into a body of water like a lake or pond and strike their head, and now they have a spinal cord injury. So it's always important, if you're going to dive, make sure there's nothing under the water that you can't see that you could hit your head on. And also falls. Falls are, and even jumping out of balconies over spring break, something like that can happen when people get inebriated. So preventing falls and not, taking unnecessary risks. Also taking precautions when playing sports. So again, crash helmets are going to be important, in sports, especially like football, etc. And as we say, don't drink and drive. It's amazing the risk that people take when they're under the influence and they don't even realize it, that they can lead to spinal cord injuries. So now let's talk about spinal shock, and then we'll talk about neurogenic shock. We want to discuss spinal shock first because this happens immediately after injury. Okay. The intensity and the duration vary with spinal shock depending on the level and the degree of injury. Okay. But what spinal shock is that temporary suppression of all reflex activity below the level of injury. One reflex, and you don't need to know this, is more for EMS technicians and personnel. They use a reflex called the BCR, which stands for bulbocavernosus reflex, and it is useful in testing of spinal shock. Okay, as you know, EMS are likely to be the first responders on the scene of an accident, and they want to determine if that patient is in spinal shock, so they can use this reflex. And it also can be used to guide when there is the return of that reflex. Okay, the return of the reflex indicates that spinal shock is over. All right. Spinal shock is characterized by a flaccid paralysis below the lesion, the level of injury, loss of tendon reflexes. We have impaired sympathetic outflow to vascular smooth muscle that causes a decrease in blood pressure. We also have absent sphincter reflexes and tone. Okay, so you imagine what happens when you have the absence of sphincter reflexes. We can have evacuation of the bowels and other things. Okay, so that's spinal shock. It occurs immediately after injury. It does go away. It's temporary, and it is that loss of reflex activity below the level of injury. Okay, and this just reiterates those very things that we just said. The period of spinal shock can last from hours, it may just be hours, to 6 weeks. Okay, so it's nothing that should really continue past that. So don't get confused. I just want to point out this. Spinal shock can occur immediately and last hours to maybe 6 weeks. What about autonomic dysreflexia? We just talked about it. Students get that confused. That doesn't happen in the first 6 weeks generally. It's when this patient has already gone home from the hospital. So don't get those two situations confused. Okay, we don't need to know a lot of detail here with acute stage, chronic stage, and all that. But for the most, that's too much detail for us. But what I want you to know is what's highlighted here in red. And this is also making the point, comparing the two things that we'll be talking about here, spinal shock versus neurogenic shock. We already said neurogenic shock is a type of distributive shock, but spinal shock is that immediate and temporary loss of sensation and reflexes below the level of the injury. The patient becomes hypotensive. And this is what's strange, because remember, typically, if we are hypotensive, our heart rate speeds up, and going along with that would be probably a tachycardia, but definitely not a bradycardia. But you have to understand with these conditions here that the spinal cord has been interrupted by injury. So those impulses cannot travel back and forth. So we cannot control our heart rate in response to this low blood pressure. Because of damage, insult, or disease of the spinal column, the patient is bradycardic. That is a distinguishing factor, especially with our neurogenic shock. We have the BCR reflex is absent in spinal shock. When it returns, that means spinal shock is over. We have a flaccid paralysis, and it's usually immediate after spinal cord injury. Yeah, I don't really like that slide, but that's true that both of them can occur shortly after having spinal cord injury. They're very different pathways or mechanisms that result in these two different conditions. Okay, now let's talk about neurogenic shock. Really, the truth is we don't have many questions on spinal shock at all in nursing, but I was supposed to cover it in this course, so I wanted to touch on it. But this, you may have a couple questions on neurogenic shock. Again, it's not that common. Maybe in the neuro ICU or in trauma ICUs, but mostly what we see in terms of distributive shocks in the hospital are going to be septic shock. Okay, again, septic shock is going to occur much more often than neurogenic shock. There has to be some kind of spinal cord injury to result in a neurogenic shock. Okay, so let's talk about how this goes. How do we get neurogenic shock? First, we have to have injury or insult or disease or a condition that damages the brain and spinal cord, okay, or just the spinal cord injury. We have now the loss of sympathetic tone. That means that we have vasodilation occurs, okay? The parasympathetic nervous system is unopposed. So we have the loss of sympathetic tone, and we have uncontrolled vasodilation. You've probably remember that term. We've talked about it in the past. Massive or widespread peripheral vasodilation. This causes a decrease in blood pressure, and isn't that what shock is all about? So we have hypoperfusion. Our tissues are not being perfused well because of the low blood pressures. And this is what leads to our shock state. It says neurogenic shock because it's all originates or comes from injury to the spinal cord or nervous system. So the pathophysiology of shock in general, we said that one or more cardiovascular components malfunction. We have altered hemodynamic properties and inadequate tissue perfusion. That's what leads to shock. Manifestations result from the body's attempt to maintain vital organ perfusion. Okay, we try to do all of those compensatory mechanisms to maintain perfusion to our vital organs, especially the heart and brain. We do get a sustained drop in mean arterial pressure, which means we have a decrease in cardiac output, a decrease in circulating blood volume, and an increase in the size of the vascular bed from peripheral vasodilation. In other words, more blood is out there, not returning to the right side of the heart. And of course, death can occur with shock if the condition is severe enough, or if the shock state is prolonged enough. The physiologic events must be stopped. Otherwise, shock states will progress to death. So here's that reminder. Neurogenic shock is an example of a distributive shock state. Remember, with distributive shock state, we have this relative hypovolemia because of the massive widespread vasodilation, and we get a hypovolemia as a result of the fluid shifting into the tissues or those very leaky capillary membranes. All of this contributes to low blood pressure, and then the vital organs do not get perfused well. And the blood returning to the right side of the heart, there's less of it. There's less preload, there's less cardiac output, there's low blood pressures, all of those things. Now, typically, remember, with distributive shocks, the heart normally responds by increasing the heart rate to help compensate for the fact that we're not getting a lot of blood around to our tissues. But that's where neurogenic shock is different. We do not get a tachycardia or an increase in heart rate. It can't because of the injury to the spinal cord. So distributive shock states all share something in common, and therefore they're managed in a very similar fashion. They all have a problem with severe peripheral vascular vasodilation. So examples of distributive shocks are sepsis, septic shock, anaphylaxis, and neurogenic shock. So remember, distributive shocks are highly, we have widespread massive vasodilation, and remember, with vasodilation comes a decrease in your systemic vascular resistance. Okay, so those are those three: septic, anaphylactic, and neurogenic shock. This is a nice picture too, because it shows you the difference between perhaps a normal vasculature and then one where there is vasodilation and decreased systemic vascular resistance. So neurogenic shock occurs because of the parasympathetic overstimulation, and it results in a sustained vasodilation. As we already said, there's a dramatic reduction in the systemic vascular resistance, or as we say, the peripheral vascular resistance. It's the same thing. The causes of neurogenic shock are head injury or trauma to the spinal cord. That's what we're going to keep our focus on, but there are other things that can lead to neurogenic shock, and some of them are listed there for you. So certainly there are other conditions that can lead to neurogenic shock, but we're going to keep our focus on spinal cord injury and head injury. And that's what I'm saying here in this slide. These are the ones that are most common, and including spinal anesthesia. Okay. So neurogenic shock mainly affects the spinal cord, the function of which is transmitting neural signals from the brain to the entire body and back. So this is a little review slide they like to use in nursing. And it's just a review of all of the things we've talked about before. It says here at the bottom, symptoms of neurogenic shock consist of a low systemic vascular resistance, excessive parasympathetic activity, and bradycardia. So that's what I really want to highlight here, is that bradycardia, because that's going to get you the right answer on the test. That bradycardia is what distinguishes neurogenic shock from the other distributive shocks. Okay? The other distributive shocks will respond by elevating the heart rate to compensate for that low blood pressure, but that cannot happen in neurogenic shock because of the spinal cord injury. So they have bradycardia. But truth is, other factors could stimulate over excessive parasympathetic activity. So, but I'm not going to worry about those right now. Okay, so you can look over that. Damage to the sympathetic pathway in cervical or upper thoracic spinal cord leads to a loss of sympathetic innervation of the heart. The key feature is a low heart rate despite drops in blood pressure. The loss of vasomotor tone plus the decreased blood pressure plus the low heart rate are what characterizes neurogenic shock. But I put a big star here because it is the low heart rate or bradycardia, even when the patient has low blood pressure, that distinguishes neurogenic shock from other types of shock. Okay. And how we treat shock, neurogenic shock. Fluid replacement therapy. We like to give IV fluids, crystalloids, or we can give blood products. And in general, fluids are the treatment of blood products for hypovolemic shock. That's true, we know that. We also use fluids for septic shock. We use fluid for neurogenic shock and anaphylactic shock, which all three of them, as you know, are distributive shocks. So yes, because the distributive shocks are a relative hypovolemia, so we use fluids to treat that. You can use fluids alone or in combination. We can use crystalloids, we can add in colloid solutions, and we can even use blood products when they are available. But again, the whole point is to restore volume to the vasculature to make sure that the circulatory system does not collapse. Now, fluids should be administered in massive amounts through 2 large bore peripheral lines or a central line. It's great if they have a central line in the ICU, but if not, then we need to have 2 large bore. And again, by large bore, it can be 14 gauge or 16 gauge. It doesn't matter, just so it's larger than our usual 18 or 20 gauge needles there. Take care when managing these patients. The blood pressure may not be restored by fluid resuscitation alone. We know that. Sometimes it requires the addition of vasopressors after fluids are filling the tank, so to speak. We also need to be careful about administering too much fluids. Okay. Because again, excessive fluid can lead to pulmonary edema. Okay, fluid volume overload, all this fluid can't get pumped forward and backs up into the lungs, and then they cannot breathe. Okay, so it is valuable to have a CVP. So central venous pressure reading will allow us to monitor the patient's fluid volume status. Okay, in the emergency room, how do we treat these patients who have a spinal cord injury? We need to focus on maintaining their ability to breathe. Of course, that's the priority, especially when there's been spinal cord injury. We don't know what kind of injury has occurred. Does it involve the cervical region? If we move the patient, is that going to then cause damage in the cervical region? And so breathing, of course, becomes our first priority. We also then want to prevent shock. So yes, you need to get some large bore IVs started and to begin the fluid resuscitation. Immobilization of the neck is very important. Okay, this needs to be done, even before they get to the emergency room. EMS personnel will know to place a neck brace for immobility. This is a priority because if you do not stabilize the neck, then they run a risk that movement will cause damage in the cervical region, and then the patient can't breathe. So that is very, very important to immobilize that patient's neck to avoid the complication that can result from further damage. Okay. We also want to avoid complications such as stool or urine retention, respiratory or cardiovascular difficulties, and the formation of DVTs in the extremities, because now they are paralyzed, and so they are more at risk, predisposed to forming DVTs. Now, this is rather controversial in terms of steroids in the treatment of patients with spinal cord injury. But I will teach you about it because I'll leave it up to the physicians to argue about whether or not they want to use steroids in the treatment. I realize that there is conflicting information, but nursing students still need to know this concept, how important the use of steroids is in the treatment of acute spinal cord injury. We like to use things like Solumedrol because it fights the inflammation, and it actually improves or prevents the evolution of secondary injury. Okay, so that's a very important step. Remember, steroids, anti-inflammatory effect of steroids that can be beneficial for spinal cord patients. Again, we already mentioned immobilization, but traction also is used once in the ICU to stabilize the spine and bring the spine into proper alignment. Okay, so looking at the picture really helps you to understand how important immobilization is, because look at that crushed vertebrae. Any movement can lead to severing of the spinal cord or the spinal nerves that come off of the spinal column. So that's why that is so important. Also, surgery may be necessary to remove fragments of bones or any other foreign object that's there, whether it's a bullet or whatever. And then we can have herniated discs that may need to be surgically corrected. So surgery may be necessary to stabilize the spine and to prevent future pain or deformity. So the cause of neurogenic shock is a high spinal cord injury and also spinal anesthesia. The pathophysiology is essentially an interruption of sympathetic vasomotor input, or you can think of it as excessive parasympathetic activity. This is also what distinguishes neurogenic shock from other shocks. We already mentioned the bradycardia, but here the extremities do not get cool and pale and clammy, but instead are warm. Okay. The treatment is fluids, and then if needed, they can use a vasoactive medication to clamp down on those vessels, and some of those examples would be norepinephrine as a vasoactive agent, as well as phenylephrine.